Hi, I'm Jessica Glennie. I'm a nurse practitioner in the ILD group with the Cleveland Clinic in Cleveland, Ohio. Today, I'm going to answer a tough question, which is, how do we distinguish between worsening PH-ILD and worsening ILD, worsening progressive pulmonary fibrosis or worsening ILD. And this can be a really tough thing sometimes to determine. So these patients can have very similar symptoms. So they may present to you with shortness of breath, worsening shortness of breath. They may have worsening exercise or activity tolerance or worsening fatigue. And so sometimes it can be hard to know, is this patient, do they have ILD that's worsening, or could there be some pulmonary hypertension that's coming about? There are some other symptoms that sometimes can help push us in one direction or another. So if your patient has worsening cough, especially that worsening dry cough, that might be one little sign that the ILD is worsened. Perhaps they come to you and they say, I'm having syncope or near syncope, lightheadedness, and I'm having some lower extremity edema. That might be a sign that maybe there's pulmonary hypertension here. And in fact, those would be signs that things have kind of gotten off the rails, that the pulmonary hypertension at this point is pretty bad and there's some right heart failure. But all of those symptoms aren't very specific. There can be other things that could be going on causing those symptoms. So we really do at this point have to lean on some of our testing to know if our patients have worsening ILD versus PH. So a few things that we can do, labs. So specifically what's called an NT-proBNP. NT-proBNP can be a marker of right ventricular strain. And so if we're seeing that there's a higher NT-proBNP, that there might be more fluid on board, there might be more strain on that right side of the heart and push us towards PH. We also get spirometry and diffusion capacity. Those can be very helpful. So our patients with interstitial lung disease, we're really looking at their lung capacity, their forced vital capacity. And if we're seeing that forced vital capacity is coming down, then we're thinking maybe that their interstitial lung disease has gotten worse. So that forced vital capacity measures, of course, how much air those lungs can hold. And if those lungs are becoming more stiff with more pulmonary fibrosis, or they have more inflammation, then patients aren't going to be able to open the lungs as much and carry as much air. We also look at the diffusion capacity. Now, diffusion capacity is not specific to one disease or another. This tells us how well that oxygen is kind of diffusing across the alveoli into the capillaries. And this can actually be affected both by interstitial lung disease as well as by pulmonary hypertension. And so, if we're seeing that diffusion capacity is coming down, it could be either or. But one way maybe to push you to one way or another is, if that forced vital capacity that we just talked about has stayed the same, but the diffusion capacity is dropping, then perhaps that's pH that's causing that, because remember, our FVC is a good predictor of our interstitial lung disease. So if that stayed the same, then maybe the diffusion capacity dropping is more related to pulmonary hypertension. And so actually there is sometimes a ratio that's talked about, a FVC to DLCO ratio. So if you calculate that and your patient is greater than 1.6, then that might push you towards pulmonary hypertension as being kind of the driver of the symptoms or the thing that's worsening. So for example, if you had a patient with an FVC of 70 and a DLCO of 36, that's quite discrepant. So you might start thinking about pulmonary hypertension. Another test that we use is the 6-minute walk test or a DSAT test or an ambulatory oximetry. There are a few different titles to these different walk tests, but in any case, they tell us what's going on with the patient's oxygenation. And if I see that a patient has really changed a lot with respect to how much oxygen they're requiring, either not requiring oxygen at rest to now requiring it at rest, or their oxygenation has gotten significantly worse. They're needing a lot more oxygen with exertion, now needing, they needed 2 liters and now they need 6 liters, or even a non-rebreather, like 15 liters. I think a little bit more about pulmonary hypertension. A stark change like that makes me think pulmonary hypertension. But again, this can happen with interstitial interstitial lung disease, like a acute exacerbation as well. So it doesn't necessarily mean that it's pulmonary hypertension, but I really do think about pH with a sudden drop in their SATs. And then walk distance can also be something that we can see drop with both. So again, it's not very specific, but a significant drop. Sometimes I think a little bit more pH. And then we go to some of our other testing, like our CT scan. So our CT scan, if we're really, trying to discern, is this worsening interstitial lung disease? That can be a really big player. So we will send for what's called a high resolution CT of the chest. So these are thin slices of the chest. So 1 millimeter usually slices is what they get. It really gives us a lot of detail as to whether there's worsening fibrosis or inflammation within the lung. And that can tell us whether, certainly that can be a good indicator of, this is more ILD that's driving the patient's symptoms. And then lastly, the echocardiogram. So the echocardiogram, we're looking for a few different things with respect to pH. So one would be just looking at that right ventricle. Is the right ventricle size enlarged? Is it, is that right ventricle dilated? Is the right ventricle not functioning as well as it should? Is the RVSP, the right ventricular systolic pressure, is that elevated? So generally that's about 35 or below for pressures. But if your pressure is greater than 35 millimeters of mercury, then, that might be a sign there could be some pulmonary hypertension. So one other value you may see is the TAPSE, which is the tricuspid annular plane systolic excursion. It's not on every echo, but this can be a sign of right ventricular failure. And if we're seeing a value of greater than 17, that may be the case. And then also looking at the septum, sometimes the cardiologist may read that the septum, the intraseptal area, is flattened. So the pressure on the right side of the heart is really pushing that septum more towards the left. So it'll be flattened or pushed towards the left side of the heart. So those are kind of all of our pieces that we gather to try and decide, is pulmonary hypertension or is worsening interstitial lung disease driving our patient's symptoms? And so we may have to be detectives and gather all of these things together to really determine. If you really feel that your patient's pulmonary hypertension is worse or they're developing pulmonary hypertension, then going on to a right heart catheterization to really be the gold standard assessment of whether that patient has pulmonary hypertension. So I hope that was helpful for everyone to kind of help them when they're putting on that detective hat to try to discern whether this is pulmonary hypertension or where this is worsening interstitial lung disease with their patient that they're seeing in clinic. And if you would like any more information, please feel free to go to the ILD Community Network site for more information. Thank you so much.